This is an eJournal club discussing the article on the role of high intensity focus ultrasound as a symptomatic treatment for Parkinson's disease. This article was submitted by our movement disorder fellow, Dr. Erin Smith, and I am basically summarizing all the information that she has provided about this article without much of my own interpretation, but I will make some comments on some of the things as I review the information. So, the article is basically a very useful article as it provides a summary of useful historical information on lesioning for Parkinson's disease leading up to the advent of focus ultrasound. It is a very comprehensive overview of all the data we currently have on MRI guided focus ultrasound, which allows us to best inform our patients. And it is very pertinent article as there is an increasing awareness among patients of this opportunity and a possibility of treatment, and is thus often asked by the physicians. The three critiques provided by Dr. Smith on this articles include: number one, that all the studies for each target provided are completely non-homogeneous. So it is just a summary which is non-comparative. There is no way to compare the studies in any way, shape, or form. The second critique is that the large multi-center study for GPI, globus pallidus interna, was only including patients with sharply asymmetric symptoms with late disease, which is highly unusual. It is considered a contraindication or a rule out factor for Parkinson's disease and may not be generalizable to a real population of patients where the disease is not sharply asymmetric. And number three, that there are not yet any studies comparing focus ultrasound directly with deep brain stimulation, and there is no significant long-term follow-up for these patients. And my own critique after review of the information is that most of the studies reviewed are open label or only single blind. There is overall a lack of double blind studies. So, with that critique and support of this article, let's look at the abstract. What is this study going to provide us? So, the abstract basically summarizes what the paper is going to tell us, that for the VIM or ventral intermediate nucleus targeting for Parkinson's disease, there is one double-blind prospective randomized controlled trial, which was for tremor predominant Parkinson's, because VIM is for tremor only, and it showed a 62% improvement in tremor compared to only 22% improvement in the sham group. Secondly, for the STN targeting, there is one open label trial which at 6 months does show significant improvement in rigidity of 71% and tremor 77% and some improvement in akinesia of 36%. Third, for the GPI targeting, there are two open label trials, both at 6 months showing about a 52% improvement in dyskinesia score and 45% improvement in overall motor scores. It's interesting that the GPI targets study were looking at dyskinesia as one of the main outcomes, knowing that that you can stimulate with the deep brain stimulation, the GPI, to block the dyskinesia. And then the abstract lets us know that VIM has been approved by FDA for Parkinson's disease tremor. And then for STN and GPI, we need more studies to understand the full impact. And it summarizes very nicely in the abstract the three important issues with the study so far. Number one, durability of lesions. We don't know how long the lesions will last and if the symptoms recur. And in the short period these studies were done, we're already seeing recurrence of symptoms. Number two, that ideal timing of procedures in regards to the onset or disease duration is not addressed. And number three, that safety of bilateral lesions is not addressed, and many studies chose to only do unilateral surgery. So with that background and summary, let's look at first the summarization of the historical background of lesioning. So the concept of lesioning began in 1930s when the surgery were done by Dr. Russell Myers with the extrapyramidal lesioning in 1939. In 1947, stereotactic lesioning using a frame was introduced. And in 1952, accidental pallidotomy was done when anterior choroidal artery was ligated accidentally by Dr. Irving Cooper, which actually led to resolution of patients post-encephalitic Parkinsonian symptoms and led to follow-up of multiple surgeries with the use of ligation. In 1960s, the levodopa was discovered being highly effective and the surgeries were put on back burner. But even before then, in 1950s, high-intensity focus ultrasounds was already being used to create lesions in the brain. However, the challenge was that back then the technology was not in high intensity enough and it required a craniotomy so that you can remove the skull and then have a chance of creating a lesion deep in the brain without cutting into the brain. Now we do it without cutting the skull. What the procedure is doing as a transcranial acoustic delivery of focus ultrasound and is paired with a magnetic resonance thermography that allows for a very strong precision of the lesion. But the challenge is, as we will see, that some patients can have a thick enough or a high enough density of a skull that the focus ultrasound cannot be reached to a high enough temperature to cause the lesion in the brain. Similar problem that Dr. Russell Myers was having, so there is still room for improvement on the technology. And magnetic MR guided focus ultrasound is approved by US FDA for essential tremor and for Parkinson's disease tremor. So with this background, let's look at what evidence we have for thalamartmy so far, which is the primary target for the tremors. So the first study by Schlesinger was a case series of unblinded 7 patients with refractory Parkinson tremor, and it was a unilateral ultrasound and has anywhere from 3 to 12 months of follow-up. And what they found was that the UPDRS improved by about 50% at 1 week post-op, and the PDQ-39 Parkinson's Disease Quality Index was down by also about 50% at 1 week post-op. And looking at case series, 1 patient had improvement in rigidity, but while 3 patients had recurrence of symptoms at 1 week, 1 month, and 6 months post-op. And that leads to that question about durability of lesion. Adverse effects were transient, including gait imbalance. That is a common theme we will see often during other studies, and hypoacusia. And then the same study group later looked at 12 Parkinson's patients and 18 essential tremor patients. So about 30 patients with tremors look for improvement, and they reported that 34% decrease in UPDRS, but it's not a good measure if you're only improving tremor, and 32% improvement in PDQ-39. And again, unsteady gait was the most common adverse effects, but only lasted less than 3 months. So time about where there is swelling inside the brain that gradually goes away. 4 of the Parkinson's patients had tremor recurrence within 6 months. So that's about a third of patients with Parkinson's, the 12 patients with Parkinson's. So that's a very low durability of lesion, or maybe that the lesion was actually small. The initial benefit was seen because of the swelling from the lesion around it was bigger and was including the area which you needed to get a tremor resolution. But eventually, once the swelling went away and the final lesion set in was too small to include the area of tremor improvement, that's why the tremor was gone. And that's one of the challenge with this therapy. So looking at the other studies by Dr. Fasano, who did a single blind study only on 3 patients with tremor predominant, and their results were less, they were underwhelming. 1 patient died from aspiration pneumonia and had hemiparesis and hemi-anesthesia. Only 50% improvement in tremor, and 1 patient had to repeat and focus ultrasound at 18 months because of not having enough tremor control. And there was no change in motor UPDRS score overall, despite probably the tremor improvement, and no other symptom besides tremor improved, and thus why. Similarly, the study by Bond et al. Is the only double-blind prospective sham-controlled randomized control trial, and actually involved 2 centers where they did 20 patients with the Axial treatment, and 7 patients were in the sham group, and they measured the clinical rating scale for tremor. So focusing on tremor as well as the motor UPDRS, and they found a 62% improvement on the clinical rating scale for tremor compared to 22% in the sham, which was the placebo effect. And as we know, the placebo effect is very common in Parkinson. And also in UPDRS, there was an 8-point improvement, which is significant because we are doing VIM surgery, which tends to only improve tremor. PDQ-39 was improved. And then when the blind was lifted at 3 months, 6 of the 7 patients who had not, who were in the sham group decided to go ahead and convert into actual surgery. The common side effects was paresthesia in 20%, 1 in 5, and only 4% with ataxia, which is very, very good result because ataxia typically is more common. And there was mild hemiparesis again, was transient, and that was probably due to unintentional involvement of the internal capsule. And then finally, the Sperling et al. Went back and looked at the same patient data and looked at the effect on cognition, mood, behavior at 3 months follow-up, and they found no difference. So this was pretty good study showing a very reasonable improvement of 60% on tremor. Also improvement on UPDRS of 8 point, which was not shown by Fasano, and is reassuring in terms of side effects are being transient. Going to the next target for Parkinson's, for subthalamotomy. Now, VIM is an FDA-approved target, and this is what a VIM lesion looks like on the MRIs on Axial and sagittal and Coronal on a T2, and you can see some white area around is probably the swelling, which is still there in this area in the center, but this probably will become smaller as the swelling goes away. And this is 1 day after the procedure, so there is clearly a lot of edema around it that will gradually go away. VIM is the only FDA approved target so far, but what is known about subthalamotomy so far is that when we were studying the MPTP model, Dr. Mehlon DeLong, who described the SDN's role in Parkinson's disease and the direct and indirect pathways back then, was using an MPTP lesion monkey. They were lesioning subthalamus with good improvement in the monkey's Parkinson's symptoms. So there is there have been a previous study of 89 patients with lesions of subthalamotomy, before the use of focus ultrasound. And in those patients with the subthalamotomy, there was an improvement of UPDR score of 50% at 12 months, 30% 24 months, and then 18% 36 months. So a gradual loss of benefit over 36 months with improvement coming down significantly. There has been only one study, which is an open trial using 10 patients, which used the focus ultrasound for lesioning the subthalamus and had a really promising result. There was a 53% decrease in the MDS-UPDRS in the off state at 6 months, and the decrease was 47% in the on state as compared to the on state before surgery. So still really, really significant improvement on top of the use of medication. Tremor responded really well, 77% improvement, and also rigidity of 71% improvement. However, akinesia improved less at about 36%. And they also needed medication less often, as we see with the deep brain stimulation surgery of the STN. There was a 24% reduction in levodopa dose, which is less than what we will see with DBS, where we can see a reduction all the way up to 40 to 50% of levodopa dose equivalent. However, 24% reduction is still significant. And the side effect included hemichuria in one patient that lasted 6 to 12 months before going away. However, the most common side effect was ataxia, as mentioned before, gait instability, and seen in 6 out of 10 patients that lasted for a short time. Now, this is the axial and coronal sequence T2 of the STN lesion, and you can see the bright lesion on the right side of STN on the axial and the coronal one. And again, this is 1 day after subthalamotomy, so there is a lot of edema, and the lesion looks relatively bigger. Eventually, as the swelling goes down and the scar formation happens, the lesion will look smaller than this. Going to the third target for Parkinson's disease, which is the GPI. In GPI, we have prior experience of non-invasive lesioning using radiofrequency ablation, and that has been established as a benefit to reduce dyskinesia. That's the kind of patients that have been targeted often for GPI. Patients who are taking medications are very dyskinetic from it, but there has also been improvement in the motor fluctuations and other Parkinson's symptoms. The DBS has been used to overcome it has been preferably used over radiofrequency because of the side effects that we see with radiofrequency ablation of weakness and imbalance and cognitive abnormalities, visual field effects, and so on. And especially with the bilateral lesioning, we see these problems. The first case of using the focus ultrasound was in 2015, which showed a 62% reduction in the dyskinesia rating scale at 3 months and 62% reduction in the off UPDRS or Unified Parkinson's Disease Rating Scale in the off state. And then the open label study of 10 patients was done by Jung et al. And it showed 2 patients not having a successful ablation because of their unfavorable skulls. As I mentioned before, that still is a technique limitation if the skulls are too thick or too dense. 6 of the 10 patients, so that means 6 of the 8 patients who actually had the surgery, they had 1 year follow-up, and they showed a 52% decrease in the dyskinesia scale. Again, probably they're taking the same amount of medication as before, and although they were becoming very dyskinetic with their medications in the past, now they can take it without getting that much dyskinesia. So more of an anti-dyskinesia treatment, and 30% reduction in the off-motor UPDRS on top of what they were having from the medications in the past. There was some dysarthria and hemiparesis in one patient, but only for a couple of days. And neuropsychology testing remained unchanged, and MRI lesions improved gradually over 6 months. A larger multi-center trial is underway, and there is an open label phase which is currently unpublished data by the authors that is being reported in the study, where they're saying that in their open label large multi-center study they decided to do only unilateral procedures given the concerns for adverse effect of cognitive effects from bilateral surgery. And so far they have done 20 patients with unilateral or highly asymmetric symptoms, again which is considered typically a red flag because they're patient on an average disease duration of 10 years. So having a highly asymmetric disease after 10 years of having Parkinson's symptoms is considered against the diagnosis of Parkinson's disease. But some patients just have so much more of a tremor on one side or symptoms, and they are relatively younger patients. So average age is 56.8 years, not old people. Again, something which is atypical for regular Parkinson's. So if their average age is 57 years and they have 10 years disease duration, so average age of onset presumably is 47 years for this group. Again, this is a very, very young group with Parkinson's disease, and the average levodopa dose is about 1,000 milligram of levodopa daily, or 10 tablets of Cinam at 25-100 milligram. They report that 19 of these patients have made it to 6 months follow-up, and they are again reporting a dyskinesia improvement of 50%, again focusing on dyskinesia improvement, meaning that the patients were very dyskinetic and they continued the same dose and now they're less dyskinetic. But there is clear motor improvement with Parkinson's, and there is a 45% improvement on the UPDRS score as compared to before the surgery with medications alone. And of course, significant improvement on activities of daily living. Adverse effects were common. There was a problem, 1 mild transient visual field effect. There were 2 mild and 2 moderate dysarthrias. 3 of these 4 persisted for a long term, so they have only 6 months follow-up. Neuropsychology changes in 1, in memory, fine motor deficits in 2, and 1 is persisting long term, 1 facial weakness, and 1 having moderate and persistent balance problem. So of course, the lesioning, although even unilateral in these patients, is not without any problems. And this is what the lesion will look like on an MRI on Axial slices. This is an MRI sequence from 1 day after the procedure, and surprisingly there is not that much of an edema, and the lesion is posterolateral globus pallidus interna, which is the typical location for all the lead placement and pallidotomy. So what they are describing based on this review is that focus ultrasound with MRI guidance is a good incisionless option, and VIM is very comparable results to the radiofrequency ablation. And although they say it's comparable to DBS, I am not very convinced so far by looking at the data they have provided. And then they're saying that the bilateral lesions of VIM and GPI that have been looked at can cause permanent side effects of dysarthria and ataxia and maybe even cognitive impairment. However, bilateral STN might be okay, but again, the data is very limited there. So what we still need to establish is the long-term durability of this procedure, as we have already seen loss of benefit in quite a few patients with this small number of patients in the studies. And we need to see if there are other imaging techniques that might be more useful, such as the diffusion tensor imaging or DTIs, and maybe treating patients in early Parkinson's disease might be of more benefit, although they did have a young group in the Pellet.me open label study data they are proposing. So this is the summary, this table 1 of the trials that were looked at in the study, including the target for VIM, 4 of them, 1 for STN and 1 for GPI, with the amount of follow-up and number of patients. Again, you can see the number of patients is very, very small as compared to the DBS studies or many other Parkinson studies where the numbers are in hundreds. So this is still something that we are gradually learning about and getting more and more comfortable with. I again would like to thank Dr. Erin Smith and make sure that I repeat that the credit goes to Dr. Smith for reviewing this paper and summarizing all this information for me that I was able to present on this video.